Hello, my name is Godwin Osei-Poku. I'm the Research Analytics Manager at the Betty Lehman Center for Patient Safety. I'll be walking us through this poster, which is titled Racial and Ethnic Inequities in Severe Maternal Morbidity in Massachusetts. As a form of introduction, in the last couple of years, mainly in 2014, nearly 50,000 women experienced serious pregnancy complications, or what we call severe maternal morbidities in the United States. Data from the CDC indicate national increase in rates of SMM, and we have similar trends in Massachusetts. PINQUIN, that's the Perinatal Neonatal Quality Improvement Network of Massachusetts, a statewide perinatal quality collaborative, aims to eliminate preventable severe maternal morbidity, mortality, and racial and ethnic inequities in maternal outcomes. To do this, we examined state-level trends in severe maternal morbidity and also examined variation and disparities in severe maternal morbidity by race and ethnicity. For our methods, our data source was mainly hospital discharge data, which is collected by the Center for Health Information and Analysis of Massachusetts. We examined birthing people with a delivery hospitalization from January 1st, 2016 to June 30th, 2019. We used the CDC algorithm to identify deliveries with severe maternal morbidity and calculated severe maternal morbidity rates both with and without transfusion. We also estimated trends in severe maternal morbidity using the Cochrane-Amite trend test and further use logistic regression analysis to control for patient and hospital level characteristics. In terms of our findings, we have noticed that severe maternal morbidity has increased in Massachusetts. If you look at the charts displayed above, for severe maternal morbidity rate without transfusion, it increased from 85 per 10,000 deliveries in 2016 to 98 in 2019. The p-value of our Cochrane-Amite trend test was 0.0049, which makes it significant. Severe maternal morbidity rates with transfusion also increased from 179 per 10,000 deliveries in 2016 to 241 in 2019, and the p-value for our Cochrane-Amite test was also significant. In terms of racial and ethnic disparities, there are still significant racial and ethnic disparities in severe maternal morbidity rates in Massachusetts. Black non-Hispanic birthing people have nearly twice the estimate rate of white non-Hispanic birthing people, and Hispanic birthing people have nearly 1.2 times the estimate rate of white non-Hispanic birthing people. The chart just shows this disparity clearly, where you can see that the black line is significantly higher above that of the other racial groups. These disparities also remain even after we adjust for patient and hospital characteristics. As you can see from the forest plot shown here, Black non-Hispanic birthing people had nearly 1.7 times increased odds of severe maternal morbidity compared to white non-Hispanic birthing people. And Hispanic birthing people had nearly 1.15 times increased odds of severe maternal morbidity compared to white non-Hispanic birthing people. And these odds are significant. For mothers who identify as other race, they had nearly 1.08 increased odds of severe maternal morbidity compared to white non-Hispanic birthing people. However, this was not significant. Our model adjusted for age, insurance, teaching status, proportion Black serving at each hospital, volume of patients, and ownership or tax taxes. However, the results of these variables are not shown in this forest plot. In conclusion, the rising estimate rates in Massachusetts reflect national trends. There are still significant racial and ethnic disparities in estimate in Massachusetts, with Black, non-Hispanic, and Hispanic birthing people having the highest rates of estimate. In terms of policy, PINQUIN is implementing the AIM bundles, which provides an opportunity to share tailored estimate reports with each birthing hospital and supporting the hospitals in their efforts to implement these safety bundles. Our main focus is on reduction in peripartum racial and ethnic disparities. So through collaborative learning and sharing of best practices, PINQUIN is working with hospitals and using quality improvement science to improve outcomes and achieve equity. Our study, however, is limited by the use of administrative data, which may be subject to coding errors by medical coders. However, we believe these coding errors were minimum and did not affect the findings of our study. These here are our references that we use for this study. You can contact me if you have any questions. Thank you so much for your time.